I mentioned earlier when we did skin that they were apocrine glands, modified sweat glands, kind of like,
Larry, you're really falling on your job.
come on,
The button lit up.
is that light on?
Yeah.
Turn on.
Okay. Clinically, you divide the breast into 4 quadrants. They're not anatomical quadrants, but clinically you divide them into 4 quadrants. If I say you have a breast mass in the upper outer quadrant or lower inner quadrant, you need to describe it that way. There are also the tail of Spence, which is the part of the breast that extends up into the axillary region here. That's included with it. Areola, of course, is a hyperpigmented structure that surrounds the nipple. The areola has, in this slide, these little protrusions that are called Montgomery glands. They secrete an oily substance that helps with lubrication during lactation. Some are more prominent in some women. In some women, they're more prominent than others, especially after you've been through lactation. The gland itself is divided into lobes, and in each lobe is divided into lobules. So if you look at it, here's the nipple, there's a duct, and then you'll have 15 to 20 lobes, and then each lobe is further subdivided into the lobules. At the end of the lobules, you'll have glandular tissue that will secrete the milk. The blood supply, the venous drainage, lymphatic drainage, we'll talk about here in just a second. The innervation is from about the second T2 to around T6 intercostal space nerves. They're branches from the intercostals that we'll talk about when we get to the chest wall. If you look at the structure, you need to understand that this is in the subcutaneous tissue. Therefore, it's superficial to the deep fascia of the pectoralis major. It's superficial fat and glandular tissue, just like any other sweat gland of the skin. It is superficial to the deep fascia of the underlying muscle, in this case, the pectoralis major. Here is a cross section. You'll see the pec major with the fascia there. The skin of the breast has these connective tissue. If this is the breast here, has these connective tissue bands or strings. They're like strings that run from the skin to the deep fascia. These are called Cooper's ligaments or suspensory ligaments of Cooper. And they're the ones that give the breast its, how do you say, upright or, up. As you age and you have if you're lactating, the glandular component enlarges and actually puts pressure on the Cooper's ligaments. As you age, they become more lax. So, of course, as you age, the breast tend to fall, if we can use that term. Okay. The duct system is very important because 99.9% of breast tumors arise from the ducts. Milk is produced on stimulation by prolactin, which is secreted by the pituitary. So after you've delivered a child, the prolactin levels will increase from your pituitary gland, and your breast will swell. Yeah, but the flow of milk occurs because of another hormone called oxytocin. Oxytocin causes what's called the milk letdown reflex. So prolactin stimulates the production of milk, and oxytocin is not up here on this slide. Oxytocin actually provides for the discharge of milk. The blood supply is listed here. The predominant blood supply comes from the internal thoracic, which is what you're going to dissect today. You also get contributions to the lateral breast from the lateral thoracic and from the intercostal arteries. You see the intercostal artery at the bottom of each rib there? They're going to also supply small branches into the breast, but the predominant arterial blood supply is via the intercostal. The lymphatic and the venous, by the way, the venous drainage is through the axillary area.
Which you said was the main blood supply?
Internal thoracic. That's this artery right here. Yeah, that one. Okay. The lymphatic drainage is probably the most significant item to consider with the breast. Of course, the vascular supply is going to be important with breast surgery, but the lymphatics in terms of breast cancer, most of the lymph from the breast drains towards the tail of Spence, or towards the axilla. 3/4 of it will drain towards lymph nodes in the axilla. That's why it's so vitally important when you're doing a breast exam that you feel the axillary nodes. You feel for the axillary lymphadenopathy. There's a thing called a sentinel node that if a lesion is identified, and it's identified by a fine needle biopsy, where they stick a very tiny needle into the breast mass and biopsy it. If it's identified as cancer, what they do then is they'll put a contrast material in there and watch to see where it goes. The first lymph node that concentrates the contrast material is called a sentinel node. That's the node they go after to find out if you have metastatic spread into the lymphatics. On the incidence of breast cancer, you see that most breast cancer occurs in the upper outer quadrant and tail of Spence. 2/3 of it essentially occurs in that area. This is what breast cancer looks like on a mammogram. This is a normal mammogram over here. This is the fibrous tissue inside of the breast. And this is calcification, which is a sign of breast cancer. Most of the time it doesn't get that bad. I mean, it's picked up earlier. What you actually see will be little spots of calcification. That's what they're looking for on a mammogram. Mammograms are useless in people your age because your breasts are so dense. They're not fatty. They're not as fatty as a more older person. So that's why they don't recommend mammograms before the age of 40. The current recommendation, according to the U.S. government, is actually all the way up to 50 now. So, if there was a lesion found in your breast, the way to approach it would be ultrasound or MRI, not mammography. Okay. When you're doing breast exams, you'll learn that the best way to do it is you start at the nipple and you palpate using the flat part of your hand, your fingers, in a radial pattern all the way out. And then feel the tail of Spence up into the axillary node, and then squeeze the nipple to see if you can express any milk that should not be coming out, or bloody discharge. It doesn't, anything coming out. There should be nothing coming out unless you're lactating. And then do it on the other side. Usually it helps if the woman is lying down, if she has her hand behind your head that stretches the breast out. Sometimes in pendulous breast, you have to use both hands. So you'll learn to do breast exams. Controversy right now exists with breast exams. Most recent recommendation from the U.S., who was that group? Did you remember the Centers for something or another? They're recommending to not do clinical breast exams anymore, or even to do home breast exams, for you to do home breast exams. Because they don't find it. The most useful thing is mammography, beginning at the age of, according to that study, 50, some studies say 45, the American College of Gynecologists and the ACOG says still 40.
If someone has a history of breast cancer in their family, should they ask, or should we advise them to get an ultrasound if they're like 30 or so?
It's individualized. If you have a breast cancer in a first-degree relative, your mom, grandma, or your sisters, then you should go into the 30s. But again, not mammography. It's not going to be useful. Whether or not you do genetic screening for BRCA1 and 2, that'll be up to you and your provider. As far as a risk factor for breast cancer and ovarian cancer. So yeah, if you have a history of breast cancer, first-degree relatives in your family, it does go earlier than 40. But again, not with mammography, which is the screening tool for over 40. One of the things that's always a concern you're going to get asked about is what impact do breast implants have on detection of breast cancer? And I don't believe that there is any data that says that, there's no data that says they increase the risk of breast cancer, or I'm not aware of any data that says they impair the ability to detect breast cancer. However, I don't think you can do mammography with implants. I think you have to rely on MRI or ultrasound. But in this picture here, you can see the breast implants on a regular. This is a normal, a plain chest X-ray. Here's the lower limits of the breast here, and you can also see the outline of the implant right there on that side. And over here. It's pretty amazing. It's always fascinates me. You come in, she comes in with pneumonia, and I send her over for a chest X-ray, and I go look to see who has breast implants. I mean, some of the people that you wouldn't, it's like somebody's grandmother. You kind of call them, you go, she's got breast implants. Here's some clinical correlations here. Galactorrhea is the condition of having something, milk produced when you're not supposed to. Again, pituitary adenoma with the bitemporal hemianopsia from the expanding tumor on the optic chiasm. There are some medications for those of you with depression who are taking SSRIs. Sometimes they have a problem with galactorrhea that will resolve when you stop the medicine or change it. Here are some pathognomonic things for breast cancer until proven otherwise. And I'll show you each of these on the next slide. Here's nipple inversion. What happens there is the expanding tumor puts pressure on Cooper's ligaments, and that actually pulls it inverts the nipple. So if anybody says that, I don't know why, but a 55-year-old woman comes in, I don't know why, but over the past year or two, my left nipple seems to have gone inside. I got an innie, not an outie. Well, that should be ringing alarm bells in your head of an underlying tumor. Dimpling, for the same reason, you're putting pressure on Cooper's, the suspensory ligaments. Poda orange here is the characteristic, it's edema of the epidermis. And the reason it has that name is that that's a picture of an orange. It's the skin of the orange. That's what it looks like. It looks like an orange skin. So it's very obvious when you see it, and it's over the area of the tumor. It's not the whole breast, it's over the area of the tumor. And over here on this poor lady, she's got lymphatic blockage of the axillary nodes from presence of cancer, and her right upper extremity is going to become lymphodematous. This is the thing that's probably the most common occurrence with the breast, and this is fibrocystic breast disease. And what this is it's a response of the breast tissue to the cyclic changes of the menstrual cycle. And the different hormone levels cause the creation of these cysts to develop during the month. And they become painful, they can be enlarged, you can feel them. They feel like grapes and peas and BBs in the breast. And then, you can do a breast exam on 2 weeks later, and they're gone. So that's how, breast cancer doesn't go away. It's always there. So fibrocystic disease of the breast is very common. Anecdotally, caffeine and chocolate, cutting back on those tends to anecdotally lessen the frequency and the severity of the disease. The way you treat it is with NSAIDs. You'll see that acronym, non-steroidal anti-inflammatory drugs. Motrin is the prototype drug here. The use of more harsher regimen, like things to affect the cycle itself, like hormones, birth control pills, or tamoxifen, which is an anti-breast, is an anti-tumor type drug, are just not recommended. Some people get really aggressive with fibrocystic disease, and it's better controlled with NSAIDs and heat. You'll see the incidence up here. It's even more people have fibrocystic breast disease, more women, than they do with normal breast. That's how frequent it is. So, any questions about that?
Does this present with pain?
Yes. It's cyclic pain. Like mid-cycle, my breasts are so tender, I mean, when the wind blows, it's painful. They have mastalgia. Is that up there? Mastalgia, yeah, that word. Mastalgia is painful breast. But then it goes away. Next month it comes back again. So it's very cyclical. That's the way you know the presence or the presence, then absence, then presence and absence of these little masses, along with waxing and waning pain or ebb and flow pain. That's that. Why are you laughing? Go ahead, get it out, get it out. Go ahead. Mastalgia, is that?
No.
You're good with it.
Okay. Did you put the word poo-pooed in there?
Poo-pooed, yeah, you don't want to do that. Poo-pooed. Poo-pooed, that was poo-pooed.
Okay.
FNA means fine needle aspiration. So if I found a mass in your breast, you don't automatically assume that it's fibrocystic disease. You want to go ahead and biopsy it. The way to do that is to take a very fine needle and you stick a needle in it and draw off some of the cells and then look at those cells. The pathologist will look at those cells and determine what it is. FNAs you do with the breast, you do with the thyroid masses, enlarged lymph nodes, you can do an FNA. So you'll see that term a lot as well, FNA, fine needle aspiration. Okay. Here's an interesting clinical correlate. The phylogeny recapitulates ontogeny or whatever else, whatever the right thing is. You have a ridge here in development. That's where you have mammary tissue that develops along that ridge. That, of course, by the time you are born, it's all gone away except for the two remaining. However, if you have a congenital malformation and they stay, you can have nipples. Now, they're not fully formed nipples, they're usually, they look like freckles layer, like right there. That's a supernumerary nipple, and I guarantee you, this right here, right at the bottom of the rib cage is where they are mostly. But they can occur anywhere along this line, from up in the axilla all the way down into the inner thigh. I guarantee you probably 2 of you in here have what you've always thought was a mole right there, but is actually a nipple. You have one? I appreciate you volunteering. Come on, show us. What's that?
What do you call those lines?
It's just called a mammary ridge, a mammary line. Yeah. It's like, you know, a dog has, you know, a bunch of nipples along that line. You have the same thing. It's just that yours went away, except for, I would say probably 5% of people have them. They're fairly common. You know, when you're doing an exam on somebody and you know, they have their shirt off, or like if you came in to see me or something and you were in a gown or a sports bra or something, and I saw a spot, I said, oh, hey, you have a supernumerary nipple. You know? It's rather alarming to some people. But you will never have one in the middle of the chest like that James Bond movie. There was some James Bond movie. What was the name of it? You know what I'm talking about? Old James Bond movie, there was some guy that had a nipple in the middle of his chest. It's not in the ridge. It's along those lines. Any questions? All right. Now, here's some landmarks, and the reason I put these landmarks in here is because you're going to use these terms clinically. The midclavicular line is just the midpoint of the clavicle, so you know, if you put your fingers on the clavicle, the midpoint of the clavicle, follow your fingers down, that's the midclavicular line. There are anatomical structures that are in the midclavicular line. On the axilla over here, you divide the axilla. There's the anterior axillary fold, the posterior axillary fold. So when I say the anterior axillary line, or the mid-axillary line, or the posterior axillary line, I'm saying in relation to the folds. When you put a pad on to defibrillate somebody, you put it in the mid-axillary line at the fifth intercostal space. So you need to know these terms. Okay? A couple of variations in the development of the chest. The one on your left is called pectus excavatum. The one on the right is pigeon chest. So it's like a ridge, like a bird has that bone right here in the middle that you cut the breast off of. That's what it feels like. It feels like a ridge in your chest. The funnel chest over here feels like it's sunken in. These are normal variants. Anybody have any one of those? No. It seems like this one is the more common of the two, although it's not usually as pronounced as in that picture. Usually these aren't symptomatic. They're just fun, you know, when you take off your shirt to do an exam, like, oh, you got a pigeon chest or pectus excavatum. That makes you sound smarter.
Is this something, are those things that you would have repaired, or you just,
No.
that's just, okay.
No, it's just, it's a variant. I'm not going to say it's a normal variant, but it's a frequently encountered variant. But mostly it's the excavatum, not the carinatum that you see. The osteology of the chest is like an upside down funnel. It's smaller at the top, bigger at the bottom. This is the thoracic inlet up here. That's the thoracic outlet down at the bottom. The notch right there where you put your finger, that's called the jugular notch of the manubrium. You feel it right there. The articular points of the manubrium are the clavicle is the most superior, and then the first rib comes in laterally, and the second rib attaches halfway between the manubrium and half of it with the body. The body is, well, first of all, the manubrium is at an angle like that. The body is more straight up and down, which produces a point. That point right here is called the sternal angle of Louis. And if you feel it like this, and it's more prominent in guys, you can feel it. There's a nut, there's a click right there. Do you feel it? Okay, that's the sternal angle of Louis. This is very clinically important. And I'm going to ask you about this again as you go through this program. Because you need to understand that the second rib attaches at the angle of Louis. The second rib attaches at the angle of Louis. This is important when you go to sticking things into chest, like central lines and needles for decompression, because you want to know exactly where the second intercostal space is. And if I ask you where you're going to stick that needle, you're going to say, in the second intercostal space at the midclavicular line. Show me where it is. Put your finger on the angle of Louis, feel the rib that attaches there, that's the second rib. You follow it out to the midclavicular line and drop down into the intercostal space. That's where you go. So always remember, second rib attaches at the angle of Louis. The body is actually made up of 4 little bones, and in some people you may feel the little that fuse. And they don't have a suture line like up in the head, really. Sometimes you can see it, but most of the time they fuse completely. But some people, thin people, you can run your finger down the body and you can feel the little bumps from the old fusion. Now at the bottom of the sternum is the xiphoid process, little cartilaginous xiphoid process. In some people it sticks out like that and it feels more like a point. In others it's more straight up and down, and it's just know that that's at the bottom of the sternum. Okay. The ribs themselves, you have 12 ribs that don't all attach, none of them attach to the sternum directly. They all attach via costal cartilages. And you see that the orientation of the costochondral junction is sort of a Christmas tree. It's like that. And people that work out too much. I'm going to start lifting weights tonight, right? So I go in the gym and I start lifting weights. I'm way over. I should not be doing it to that level, you know. Or I decided I need to start rowing. So I go down to the river sport and I get in a boat and I start rowing. And so you're using all your chest muscles. I mean, the chest moves incredibly. We're the guy sitting next to the, here. It's truly impressive. Can you stand up for me? Watch this. I mean, the chest, watch how much the chest moves. Look at that. I'm compressing, do you see how much I'm compressing his chest? That's impressive. Watch this. From the side. Look how much I can compress. Like that. Look at that. Come up here. Grab his chest. Squeeze it. I mean, I can move his ribs a good inch. From the AP to rectum, probably at least an inch. It's truly impressive. So, when you get out of the lab, give him a good squeeze. You really ought to do that, because when you start doing chest compressions during cardiac arrest the first time, you're going to really be alarmed at how much the chest moves. Okay, so part of that articulation, though, is because it's not a bony attachment, it's a cartilaginous attachment. Now, going back to my rowing thing, there's a thing called costochondritis, which is chest wall tenderness because of inflamed costochondral junctions. You see that quite frequently in the primary care office and in the emergency room, costochondritis. And understand that if I come in complaining of chest pain and it's out here, and that line, it's costochondritis. If it's heart, it's right there.
And that's due to chest, what?
Inflammation of the costochondral junction. All right, now going back to the ribs. You have 7 true ribs because their costal cartilage is attached directly to the sternum. Ribs 8, 9, and 10 are false ribs because their costal cartilage is attached to the rib above, not directly to the sternum. And then ribs 11 and 12 are floaters in that they have no sternal attachment at all. They float or are suspended or terminate in the muscle mass of your flank. Okay?
Muscle mass of where?
Your flank. This is the flank. That area. Any other questions? All right. If you would take a relationship that is really interesting to know here, if you look at the sternum, I don't care about if you're going through the jugular notch. I really don't care that you know that bisects T2 to T3. The more important one is through the angle of Louis. And not so much that it would hit the vertebra, it's that it is at the top of the heart. So your heart is below this level. There's my angle of Louis. The top of my heart is right there. So you need to appreciate during this next exam, a lot of drug buys are going to go bad. So you're going to get a lot of stab wounds and gunshot wounds to the chest. That is one important relationship. Angle of Louis, top of the heart. Now, detail of the rib, we already know the articulation of the rib here with the vertebra and how you count ribs. The different pieces and parts is there are demifacets or half facets on the head of the rib. That's the neck right there. And then right here is the tubercle of the rib that articulates with the transverse process of the vertebra that it's named. If this is the seventh rib, that's the seventh vertebra. If that's the seventh rib, that's the seventh vertebra. There's the seventh transverse process, or the transverse process of the seventh rib. Okay? Once you get past the tubercle of the rib, it takes the rib starts out pretty much perpendicular to the spinal cord, the spinal column. And then once you get past the tubercle, the rib folds like that, and it dives down. The point where it folds, that's called the angle, the costal angle. And it's very sharp. You'll see it downstairs in the ribs, in the bucket there. The costal angle. The mid-ribs, it's more obvious. When you get up to the first rib is flat, and it's pretty much just a horseshoe-shaped structure. You don't see much of an angle. Mid-ribs you do. You get down here to the 9, 10, 11, and 12, they're smaller and they just more like they're rounded. Also, at the bottom of each rib, there is a groove called the costal groove, and that's where the intercostal nerve, artery, and vein will travel. What do you call the nerve, artery, and vein below the 12th rib?
Inveg.
Huh? If you call the intercostals between ribs 1 through 11,
Subcostal.
What?
Inferior.
subcostal. Yeah, so you have 11 pairs of intercostals, you have 1 pair of subcostals. Now, on the chest x-ray here, one of the things that is very important with chest x-rays is that you want to make sure that you get good expansion of the chest. If the chest doesn't expand, then things get scrunched up and you can't make much of a diagnosis. It's not a good chest x-ray. So you want to make sure that the ribs are expanded at least to the level of the 10th rib. Now, if you look at this x-ray, I'm going to turn off the lights here so you can see it a little better. If you see here, the posterior aspects of the rib, I said, come out perpendicular to the axis of the vertebral column. So these are what you see here are the posterior aspects of the rib. There's the clavicle, by the way. So the posterior aspects of the rib. And then you've got the angle, and then the rib starts going anterior, inferior. Remember, this is an X-ray. It squishes 3 dimensions into 2. So you're not only going to see the posterior aspect of the rib, you're going to see the anterior aspect. If you see right there, there's the anterior aspect of the rib going down. You see where that arrowhead is right there? And it stops right there. That's where the costal cartilage would take it to the sternum. Cartilage, as I've said 19,000 times, is not radio-opaque. You can't see it. That's why there's no apparent connection to the sternum. All right, so when you're counting ribs, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, and there's the 10th rib. So this is a nice expansion on a chest X-ray. The quality of this chest X-ray is good. So you need to be able to look at a chest X-ray and identify the ribs, both the anterior and posterior aspect of the rib. I tell you that because, and I'll tell you to you again, that when you take a chest X-ray, if you come in hawking up green stuff, and I'm thinking, I listen to you, and you've got all these crackles over here on this side, you're having some shortness of breath, you're running a fever, it sounds like pneumonia, I get a chest X-ray, do not immediately, that's the right side of your chest, do not immediately go to the right side of the chest looking for that pneumonia. You are responsible for everything on this picture. If you happen to miss that little bony tumor sitting over here in this rib on this side, you're liable for it. Call an attorney, because they will, okay? So when you look at chest X-ray, you look at everything. And we'll teach you how to do that. Any questions? Excellent, let's move on. Okay, intercostal muscles. There are 3 layers. The muscles below the 12th rib, or where you find the 11th and 12th ribs, they don't really have the intercostals. Those muscles are embedded into the abdominal wall muscles that we'll talk about tomorrow afternoon. But there are 3 layers of muscles. The outermost superficial layer is called the external intercostal. And it starts on the back. If this is your vertebra, and here's your sternum, the external intercostal starts back here, wraps around, and it stops right about here along the costochondral junction. And then what continues is a shiny little thin membrane that you can see through. You'll see that little thin membrane right there. That's the external intercostal membrane. The direction of fibers of these muscle fibers is if you were putting your fingers in your front pockets. That's the direction of the external intercostal muscle fibers and the membrane. I was noticing yesterday during the practical, you're going to be able to see these real well. I mean, you already dissected them, to tell you the truth. Now, up underneath that, right there, with the fibers going in the opposite direction, like you're putting your fingers in your back pocket, the internal intercostals start here at the sternum, and they go around, and then their membrane is in the back. So on your chest in cadaver lab, you're going to see muscle fibers going in the opposite direction underneath the transparent membrane. Those muscle fibers going in the opposite direction are the internal intercostals. And in deep to that, fibers going in the same direction is called the innermost intercostals. The innermost intercostals are only present in the lateral thoracic wall. Lateral thoracic wall. So inside of this would be the innermost intercostals. Okay? The blood vessels, arteries and veins that travel in the chest run between the internal and innermost layers. You're going to see that in the subsequent slide, you don't need to write it down. The vessels run between the internal and innermost layers. Here is where, so dissecting from the outside, you'll see the internal thoracic arteries traveling right down on either side of the body of the sternum. Here's an example of what I just drew over there. Note that the nerve and artery, the intercostal nerve and artery, travels between the internal and innermost layer. Now, there's one other muscle that we'll have to show you. Up here behind the sternum, there is a thing called the transversus thoracis. The transversus thoracis is on the same plane as the innermost. And it's connected by a fine membrane that you're not going to be able to dissect. But that's transversus thoracis. Whoops, I'm sorry. I did it to the wrong side. It's there. That's transversus thoracis. It's off the sternum. Any questions about that? All right, here's the thing that's important. Here are the intercostal nerve, artery, and vein. Nerve, artery, and vein, or vein, artery, nerve. Van, V-A-N, from the top down. Vein, artery, nerve. Van, from the top down. They run in the costal groove. If you have fluid inside your chest that I need to get out, or if I need to put a chest tube in you, where you want to put the chest tube or the needle is on the top of the rib below the inner space, the intercostal space you want to go in. If I want to put a chest tube right here, I'm going to feel for the top of a rib and go in there. I don't want to put it through the bottom of a rib because I don't want to cut this vein, artery, nerve. I don't care about the nerve. I'm more concerned about the artery and vein bleeding all over the place. So always stick a needle into the chest or a chest tube in the top of a rib. Okay? The top of a rib. Here's the transversus thoracis muscles. They're pretty little muscles. They rise from the sternum, they go to the next rib, or sometimes they'll cross a rib and go 2 ribs up. But they're very concentrated right here on the anterior chest. When you take the chest plate off, they'll be right there. Understand that the internal thoracic arteries run between them and the innermost layer. Because remember I said 5 times already that that's where you'll find the vasculature. The thing about the internal thoracic arteries is that, and you make, I don't care if you cut them up here so that you completely remove the chest plate today, that's probably the easiest thing to do. If you don't want to cut them, leave them attached and just flip the chest plate up. Nah, go ahead and cut them. Remove the chest plate. Okay? And when we're taking off the chest, you want to go across the manubrium, like it says in the atlas, I mean the dissector, and go down laterally as far as you can. Okay, if you go too shallow, you're not going to have enough to get your hands in there. Go as far laterally as you can, and then across the above the xiphoid. You want to go through the body. If you go below, since the ribs go down here, but the sternum is up here. If you start going across here, you're going to get into gut. We don't want to do that. Come up through here. Make a little arch across the bottom of the chest, okay? One important thing about this artery here is that it's frequently used in bypass surgery. They'll go in and tie the artery off down here, dissect it free, and then anastomose it with one of your coronary arteries. So that's how your heart muscle will be supplied. We're going to see when we get to the abdominal wall tomorrow afternoon that the internal thoracics continue through the diaphragm to supply part of the anterior abdominal wall. The lungs. The lungs, when you were a little bitty embryo, you had two cavities here, two membrane-lined cavities. Your respiratory system developed from an evagination off of your oropharynx, kind of like the thyroid gland did off your tongue. Same sort of thing happens with your trachea. It starts to develop as a bud here. You get a tracheal bud. It grows down into your chest and it bifurcates into a right and left main bronchus. The right and left main bronchus will continue to divide 15 billion times until you wind up with a mature lung. But the thing is, you've got these two membrane-lined cavities. The buds grow into the membrane-lined cavities. And that's what it's illustrating right here. This was a perfect, nice membrane until the dang thing started growing into it. And when it did, think of it as if I have a balloon here, and here's my trachea starting to grow into it, I'm pushing into that balloon, right? So now I've got a balloon still lining the cavity, but also a balloon on the outside of my bud, my lung bud. That defines the pleural membranes. The pleura, which is a single-celled sheet, does two things. One, it secretes a little bit of fluid. You put a little bit of fluid in here to aid in the lubrication of your lung going up and down all the time. The second thing it does is it pulls air out of this space and actually creates a negative pressure. The lung tissue itself is made of elastic tissue. So if all you need is a negative pressure and it expands. If you release the negative pressure, the lung will collapse because it's elastic. I'll go into that in a little bit more detail later on. Going back to the membranes, you've got the parietal pleura that is adherent to the cavity, and the pleura that's on the lung is called the visceral pleura. The place where the lung grew into the pleura is called the hilum of the lung, or the root. Now, one thing I want you to see is this is not a perfectly perpendicular thing. It grows down like that, right? It's going to produce a fold later on, we'll see down here. And I just want you to appreciate that the lung grows into the cavity at an angle. One other point is, in you, these two cavities are separated. They are not connected. If you drop one lung, if you release that negative pressure and have a collapsed lung on this side, this one over here is just fine. They don't communicate. If you're a rat or a deer and you drop one lung, their cavities connect, you drop them both. Bad design. I didn't do it. Take a break, we'll come back.